Yeah, again, so I'm Gregg. Again, I'm with Encore Healthcare, and part of this talk really, for if you guys were in here for kind of the panel discussion, some of this just kind of coincidentally happens to dovetail with some of the questions that ended up, that we kind of discussed during the panel. So we want to talk a little bit about engaging physicians with patient reporting, and we're going to talk about some of the kind of 2-year findings we have kind of discovered through our telerespiratory program. So we've got several objectives for today's session. You know, we want to talk a little bit about the new healthcare model specific to DME, and talk a little bit about telerespiratory, give you kind of an introductory overview of what we mean by that. Again, we touched on some of that this morning, coincidentally. And then we'll kind of drill in specifically to one particular telerespiratory program, give you an example of what a telerespiratory program looks like. This one will be focused looking at oxygen patients, and we'll show you some of those results that have been compiled over the actually probably closer to 2.5 years now that we have had a program involving engagement with oxygen patients on behalf of some DME customers. And then we'll just give you kind of a high-level feedback of what some of the physician and clinician response to the program has been, you know, pro and con. So, and then really kind of a little bit of a quick little forward future look about where we'd like to, you know, potentially be able to take things, where we think, you know, as we kind of grow data and learn from that data, where we think we can kind of hopefully drive care in the home and the role that, you know, respiratory therapy can play in that. And so hopefully we'll, you know, conclude with a few minutes to have any questions or discussions. So in terms of, and again, this is going to be really kind of DME focused, this particular talk. So, you know, where do we really think the DME industry is headed, right? So what do we kind of see in terms of the future? What are some of the indicators? So we know that if we look at it from the CMS perspective, they've already come out with some statements where, and they've actually kind of pushed this back once already. They were initially saying by 2025 a few years ago. Now they've pushed it to 2030. CMS would like to see 100% of their payments tied to value and or outcomes-based reimbursement structure. So they really want to start looking at trying to move away from kind of that short-term focus and really start looking more at kind of a long-term model where you start to generate substantial savings while also improving quality. Now again, this was, you know, this initial kind of statement came out a few years ago and they're targeting 2025. They've since then kind of revised that and said 2030. Could CMS, you know, kind of push the goalpost back a little bit further? They could, but you know, the point is this is clearly something that's on their radar that they're looking to do, you know, sooner versus later. So when it fully gets executed, you know, we'll see. So in terms of, and I say new in quotes for a reason, right? And we actually kind of talked about it a little bit this morning, this idea of what's the new healthcare model in terms of DME. It's not really a new model, but it's this idea of value-based care. You know, value-based care has been around for a while in some form or fashion. And I think Zach was making a good point today that, you know, if we think about value-based care, you know, the majority of healthcare already operates in some form of value-based care model, whether that be your hospitals, your ACOs, you know, a lot of your large physician groups now operate in a value-based care model to some degree. But it seems to be for us on the DME, HME side, it's been kind of slow to kind of trickle over to us, but clearly it is something that is happening. And when we talk about it just at the 35,000 foot view, just kind of keep the definition as simple as possible. What do we mean by value? What do we mean by, you know, value-based care? So value really is just kind of this simple equation of, you know, quality, improving quality, you know, while also, you know, reducing or minimizing costs, right? So controlling costs. So, and we think about quality, we talk a lot about patient outcomes. Certainly outcomes is a big buzzword, but quality in the eyes of a lot of these payers and a lot of these organizations, it's not just about the outcome, although that's incredibly important. It's also about the patient experience. What's the feedback from the patient? What's the patient's perspective or feedback around the care that they're receiving? That's really important. You know, in the past we've talked with some individuals from various payer, you know, managed care companies, and one of the comments they've made to us before is, as a payer, we do not have patients. As a payer, we have members, and so it's members that we want to make sure that we're engaging with, members that we want to make sure that they're happy and satisfied with, the care they're receiving or with the programs that we're offering them under our managed care plan. So kind of that idea of the patient as consumer, if you will, is something that's really important. And again, like I said, a lot of parts of healthcare are already operating in these types of models. It's just something that's maybe a little new to us on the DME side, who have historically been used to working in more of a fee-for-service arena. I think it's Aetna, in fact, that if you look at their total annual spend, for various aspects of healthcare, somewhere between 72 and 75%, this is data as of like a year or two ago, 72 to 75% of their total payments are wrapped around some sort of value or outcomes model. It's just a lot of that is, for hospitals, for physicians, those sorts of entities. But for us in the DME, make no mistake, it certainly is something that isn't just coming, it's something that's kind of already here to a certain degree, but we're going to continue to see that growing. And I think it's kind of interesting, kind of dovetailing with that, there was an interesting market survey that actually Brightree conducted it, and they published it a little earlier this year. It was either in the spring or the summer. And it was interesting. It was really focused on interoperability and engagement, but I thought there were some interesting little kind of takeaways that I thought were kind of interesting and applicable to HME. And it's available off their website. It's a free survey, market analysis. But what they did is they went out and they interviewed and they polled 100 different DMEs. And these are DMEs across the country, DMEs of various sizes. So, local independents, kind of mid to large regional size DMEs, and then even some of the large nationals. And then in addition to the DME questionnaires, they also went out and they conducted surveys with 100 of those various DME referral sources. And again, they wanted to capture a really good cross-segment across, to be representative of any type of referral that might be out there. So they talked to, independent physicians, believe it or not, there's still a few of those out there still, kind of large pulmonary groups. They spoke to hospitals and ACOs, and they even spoke to some payers to get some feedback around state of the industry. And I think what was interesting is kind of the three of these points kind of bubbled up, I thought seemed applicable to us. One is in kind of today's referral process and referral environment, there seems to be a pretty significant mismatch between what our referrals are wanting and what at least some DMEs, not all, but some DMEs or HMEs are doing. So in fact, 96% of these referral sources, so remember, it's a little over 100 different referrals that were questioned, 96% of them said that they would be more likely or would be likely to send more referrals to a provider who had strong patient engagement capabilities. So HMEs that were really good at working with the patient, engaging with the patient, not just delivering the equipment, not that that's not important, not just instructing on the equipment, again, that's important as well, but that ability to engage with the patient, educate the patient, get that patient to buy into the therapy. Patients buy into therapy, they use it, tend to use it more, and receive greater benefits. So this idea of engaging with patients is really critically important to the vast majority of our HME referral sources. So, and that really kind of ties into this idea of outcomes, being about, patient engagement and outcomes as far as quality goes. So, in addition to that, we talk about value-based care, those 100 plus referral sources that were polled and surveyed. Value-based care payment models are already being adopted by our referral sources. So 65% of those surveyed said that greater than 25% of their revenue is now tied to some sort of value-based care arrangement. And over half of those individuals that are already getting paid in some sort of model like this are anticipating that that's just going to continue to grow over the next 12 to 18 months. So The point of it, and it's something that actually Zach, our CEO, talks about pretty frequently with folks, is this idea that we know value-based care is on the way. We could argue that it's here in some form or fashion already in the HME industry. But even if it takes longer to get here than we anticipate, even if it takes longer than the 2030 for CMS, and it takes longer for some of the managed care plans to fully implement it within our arena of HME, the thing we've got to realize as HMEs and DMEs is the fact that the vast majority of our referral sources are already operating in a value-based model. They're already operating in some sort of payment structure where outcomes matter to them. So even if we're still in kind of fee-for-service or kind of this midpoint as we transition over, a lot of our referrals are already there. So the quicker we can start to kind of cater to that need that they have for outcomes metrics, or for being able to show that we've improved patient engagement in the patients they've sent us, the better it is for us, even if we're still in a fee-for-service structure, because the more likely they are to just give us a bigger portion of their business because we're driving real value back to them as a referral. And then the third one really had to do, again, we kind of touched on this morning, around staffing. So supply chain was obviously number one, something we talked about coming out of the pandemic. That's still been something that seems to have kind of started to rectify itself a little bit. But qualified staffing, at least as of this survey earlier this year, is the top challenge outside of supply chain. So this idea of being able to find, hire, and retain qualified staff, particularly clinical staff, is really kind of top of mind and really that top pain point for most HMEs out there. And then keep in mind, while all this kind of staffing issue is out there, they still have this issue about they're under pressure to increase their number of referrals and also to increase their margin efficiencies. So hey, it's that cliche of doing more with less. And that's what a lot of HMEs are facing today. I'm sure some of you out there can agree with that. So how does telerespiratory kind of fit into this? So that was really kind of just to say, hey, we are in kind of this transitional period, and there's really a way where telerespiratory can help play a role as we transition into more of these outcome-focused payment models and increase patient engagement. So just general definition, when we talk about telerespiratory, it's simply the delivery of respiratory therapy using some form of telecommunications. It can be as simple as a phone call interaction with the patient. It can be more robust video chat, telehealth visit. It can be what we call an IVR, an interactive voice response. So it's actually an automated call that's going to the patient, and they press the button on their phone to answer the corresponding question, or even they're talking to an AI robot generated voice, for lack of a better way of saying it, right? So there's a lot of different ways that interaction can occur, but the point is it's happening between the respiratory therapist and the patient without the therapist being physically present in the patient's home. And really what we want to try and accomplish with some of these programs, and again, it's not just us as Encore, there's other companies that offer same, similar, maybe slightly different types of services like these. But really the point is to help kind of identify patients who are really progressing towards maybe a need for advanced therapy, or who have some sort of gap in care that's occurring in the home that maybe just the physician or the care team is just not aware of. Because where does the physician and the care team tend to see the patient? In the clinic, in the doc's office, ultimately maybe in the hospital. But that ability to have line of sight in the home is just typically, historically, a blind spot for the physician, for the care team. Whereas who tends to be in the home with these patients, at least somewhat on some sort of periodic basis, tends to be on the HME side, particularly when we're talking about respiratory patients. So, and again, where we think there's an opportunity here with these types of programs is it starts to allow the HME to start to form a collaborative relationship with the physician, with the care team, so that, the goal there is for the physician to not just see the HME as, the company that delivers the equipment when I order it, but the company that's there to really help serve as an extension of my practice into the home and can help me in terms of managing these patients a little more proactively. So that's really what we're trying to achieve with that. So, and again, there's various programs out here. The one that we want to talk about, or that I'll talk about specifically with some of the data coming up, is our oxygen focus program. That's the one specific to Encore. We call that Oxygen 360. But again, there's lots of other programs and other providers out there. So give you a little bit of history on kind of how this started. This was, before my time. I've been with Encore about 1.5 years, and we've been, doing these programs for about 2.5 years now. So what happened about, I guess it was probably 3 years at this point, maybe even 3.5, is Encore worked with one of their large regional HME customers. And this was a customer in one particular state who had a really good presence in that state, really good clinical reputation, and they had a lot of really key partnerships with hospitals, so close connections with hospitals, even like joint ventures. And the reason I bring that up is what that allowed for is the ability to have access into, EMR data on the patient. So you had really good insight into this patient's medical history, so there wasn't like a lot of holes in the data. So Encore did an analysis looking at their general oxygen patient base, and they looked at 10,000 oxygen patients. They had a pretty large oxygen patient base. And they kind of followed that patient from the time they were first ordered on oxygen, kind of followed them through their medical history as best they could, and kind of looked to see what happened to them along the way. And what they were able to see is eventually over time, out of those roughly 10,000 patients, 1,000 of them eventually ended up on NIV. And these were predominantly COPD oxygen patients. So about 1,000 of them, or 10%, eventually ended up on NIV. And that length of time, which I thought was pretty interesting when I first looked at this, was roughly 18 months. So from the time they first started on oxygen till they ended up on advanced therapy, the majority of it being NIV, it was about an 18-month period. And those of you that work in HME today or have worked in it in the recent past, what do we know about an oxygen patient? What's that reimbursement look like for most HMEs today? Oxygen revenue, not great. It's not what it was. I know when I first started in HME, it was back in 1999, and my first job, I was working for an independent DME out of the Tampa St. Pete area of Florida, and they paid me. I was an FTE, and once a month I'd go to the oxygen patient's house, and I'd do a concentrator check, and I'd clean their filter, and I'd talk to Mrs. Jones about how she's feeling and her symptoms, and even do some, breath sounds, and just kind of do a general check-in. And that was a monthly thing on the oxygen patients. Any of you that have been in HME long enough, you remember doing things like that? So, how often do we do that today, typically, on every, oxygen-only patient? Are we in that home doing any sort of clinical interaction? You'll be out of business in, 3 to 4 months if you do that at today's reimbursement rate. So what we know is, there's this window of time where there's minimal clinician interaction with that oxygen patient. The economics don't allow for that with any sort of regular basis. But again, being able to look at their medical record, over that time period, what we saw is once they got on oxygen, and sometimes it was, even, the minute they were on oxygen or pretty soon after, you started to see over time, changes in their symptoms, started to see the fact that, hey, they had needs for various respiratory medication changes. These patients were, kind of in and out of the doc's office, with issues around, increased shortness of breath, cough, chest congestion, mucus and phlegm that they can't cough up, any number of these kind of classic symptoms. A lot of these patients ended up in the hospital typically multiple times, 2, 3, maybe 4 or 5 times, until eventually, someone made the decision, a lot of times maybe a hospitalist, that, hey, this patient's sick enough that they, probably should now go home on NIV. And so the thought process was, what if we could kind of devise a model or a program to where there would be a way for, relatively low cost to start to re-engage with that patient with an RT, with an experienced clinician, and start to have some interaction to be able to kind of pick up on these signs, these symptoms of decline, kind of just do that general check that we used to do back when reimbursement allowed clinicians to work with oxygen patients on a regular basis. And, what's the best way to kind of avoid some of that cost is, not sending them into the home live every time. So now with the way telecommunications and, just technology in general is, this ability, to do it remotely, allows for this. So that's really the concept behind this idea of a telerespiratory oxygen program is, first and foremost, what are we trying to accomplish? What we're really trying to accomplish is trying to hopefully improve their overall quality of life and also prevent, hopefully any sort of hospital readmission or, at least pick up earlier on signs of maybe an impending exacerbation or worsening of their condition. Secondarily to that, it's this idea of, you kind of hear this, various folks talk about this idea of making sure the right patient is on the right equipment at the right time in their disease process. And it's this idea of, can we be proactive versus reactive? So versus waiting till, Mr. Smith is in and out of the hospital 3-4 times and finally goes home maybe on NIV, what if we could catch them after just the first hospitalization? Or, even in an ideal world, what if we could pick up on it just as his symptoms start to decline and the need for a medication change is there and we pick up on other things, maybe we prevent the initial hospitalization in an ideal situation. The other thing too is trying to really improve the efficiency given what's going on with staffing shortages out there these days, improving the efficiency for the RTs in that, maybe a home visit's needed. Maybe this is a pretty chronic, pretty severe oxygen patient who's right on that cusp of needing some additional therapy of some kind, and it might benefit to send the RT out there. But we want to really drill into that and make sure that it's worth the time, the effort, and let's face it, the money for the HME to send an RT out to an oxygen patient's home. So that idea of really being able to triage to maximize the efficiency of the RT FTEs that a DME would have on staff. And then, again, I'm on the sales and marketing side, so you got to have a sales and marketing spin to some of these things, right? So this ability for an HME, for their account executives, their sales teams, to be able to have a program that they can go back into their referral sources to talk about and be able to have, hopefully somewhat of a differentiator to be able to talk about what they're doing with, licensed, trained, clinicians in terms of regular interaction with these patients to hopefully set themselves apart. So what can a workflow like this look like? So I don't know, maybe a little hard to see here, but essentially, at least the way it works in our program, again, there's different programs out there, but I think this would capture a lot of that at the 30,000 foot level. So whether we're talking oxygen, we even got a few home care companies that even have a few of their nebulizer patients if they do respiratory meds, respiratory pharmacy, but it's predominantly oxygen patients. But these earlier stage patients. So we get their information from the HME. Obviously, we have a contract, so we're acting as a third-party provider with the DME. So again, in terms of what the patient is experiencing when they get a call or a telehealth visit from us, as far as they know, we're just one of the RTs that works for ABC Home Care. So we identify ourselves as hey, I'm Ray, I'm one of the RTs with ABC Home Care. We're here to, work with you a little bit. Wanted to check in on how you're feeling, go through just a couple assessments. This is information that will help kind of put together and give back to your physician and your care team, things like that. So it's always, identifying as far as the patient's concerned as being someone that's part of the care team from the DME that they know that, they have their equipment with. But the goal is the navigators interact with the patients. The navigators perform some, assessments, some questions. And then part of it's also just having that RT have a conversation with the patient. Those of you that have been doing this for a while, whether it's, acute care in the hospital or home care, in the home, I mean, you can probably attest to this, that a lot of times just being able to engage that patient in a conversation and not just kind of, go through question 1, 2, 3, although we want that data, but just make it conversational with the patient. And it's surprising some of the information that just kind of comes to the surface, through a natural conversation with these patients. And a lot of times it's maybe data that for whatever reason the patient might not tell the doctor when they're in the doc's office, 1.5 times per year. But it's the idea of kind of capturing this data, capturing, some of this patient narrative. And then, the assessments are all tied into the software. So it's really trying to maximize, software, algorithms, some of the analytics, that software can provide, to maybe bubble up some, data points that might kind of be hidden that you wouldn't necessarily normally see or think about. But then combining that with, the human element, the experience element that comes from having a trained clinician that's interacting with that patient. So the goal is not to eliminate the RT. The goal is not to minimize them. It's let's use their knowledge, and then let's also bring in software and algorithms and combine the two. But anyway, so through that process of kind of that conversation and those assessments with the patient, the software and the navigator help to kind of determine where does this patient kind of fall roughly along kind of a risk profile, kind of low, medium, and high. And that helps to determine the amount of engagement or the frequency of engagement. So the goal with the program is every 30 to 90 days, that patient's having a live interaction with the clinician. And we're working through, a couple of assessments and then just having some conversation and kind of, general wellness status check-in. So, those patients that tend to be trending more severe, we're going to call them, every 30 days. Those patients that are a little more moderate, they may be on a 60-day cadence. And then those folks that, hey, everything's good. They're, at least according to what they're reporting, they're using their oxygen. They have all the respiratory meds they're supposed to, and they seem to have good knowledge of how to use it. They're not having any real issues from a high symptom burden. CAT score is fairly under control. That patient more or less is maybe, some that we'll call in 90 days, right? And again, patient status changes. Maybe we touch point with that patient in 90 days and something has happened in that time and they've started to decline. And now they're in that moderate or that high risk profile. We're going to start interacting more frequently. But the point there is to kind of stratify them, triage them, get them on that cadence, and then start having that regular interaction with the patient. And again, that can be live call, that can be telehealth. Again, for those that are, because, don't be shocked, not every patient is tech savvy, but more and more patients are tech savvy, right? So some of them love the text, some of them, like the IVR check-in, where they're just doing, a couple of quick questions over the phone. So really what really works best for that patient, you can almost kind of tailor a program around each individual patient, if you will, and kind of that customization. And then from there, based off the data that comes out of that, we want to put that into a progress note that can go back to the HME, generally through the account executive team, although with some HMEs it goes through clinical as well, that can then be fed back to the physician or the care team. I know, especially for in the back, I just kind of want to give you a bigger picture view of what kind of a report generally might look like. But the goal with this, without getting too detailed in on it, but the goal here is to kind of, again, as I said earlier, we want the HME to kind of be seen by the clinician and the physician and the care team as an extension of the practice in the home, and being able to uncover data points that are potentially important to the care team that they just may not be aware of, because they're not in the home, right? So, kind of has some general demographic information, but then it gets into kind of the navigator's recap of what happened over the call. What are some of the chief complaints coming from the patient? Again, maybe hard to see here, but, patient may be reporting, shortness of breath when, doing their standard ADLs around the home. Patient is complaining of not being able to lie flat. patient, has, regular morning headaches or brain fog and confusion. So kind of list that out for the doc. Assess their respiratory medication. Again, we don't want to deep dive, but, at a very high level, if you think about a typical COPD treatment based off of GOLD guidelines, do they have a rescue inhaler and do they have a maintenance inhaler? And do they understand, at a high level, the difference between the two in terms of when am I supposed to use one versus the other? And are they comfortable, at least from what they tell us, being able to use that? And then some of the things that maybe we don't always think about, but, can they afford their medication or not? A lot of times, the patient can't afford it, or the patient started off with the maintenance because they had a sample from the doc, but then they went to Walgreens and it was $200 to refill and they didn't refill it, so they've just had their albuterol for the past 4 months to use. And the doc's not aware of that. So again, it's not that the doc's not ordering the right meds, but they just maybe don't realize there's some sort of social determinant of health issue that's preventing that patient from being on the medication that the doc actually prescribes. So we want to drill into that and get that back to the physician. Every physician, every care team member kind of prefers data in different ways. Some folks like charts and graphics. Some want more quick written summaries. So we've got some graphics on here that kind of plot out CAT scores. So we do COPD assessment tests, every time we have an interaction, so there's at least a live interaction with our RT. So, and we plot those over time. So we're able to give the physician, the total score plotted over time and indicate any changes that's going on, either positive or negative in that total score. But then also we think just as importantly as the total score, because if you're a care team member trying to manage this patient out of the clinic, if I use this example, I can see that I've got a patient here in the red who their CAT score is trending down, great, but now my last interaction, the CAT score is way up. It's gone up by 8 points. So something is going on with this patient. But now I just know I've got a total score increase. How does that really help me drill in? So off to the side, we put the individual answers to the questions and how each specific question was scored. And we highlight the 4s and 5s. Obviously, with the CAT test, as you guys probably already know, the higher the score, the more impacted the patient is or feels like they are being impacted by their COPD symptoms on a daily basis. So a 4 and 5 is a really high score on any individual question. And so it allows the physician or care team member to see, okay, Mr. Smith, where he's really struggling is those first 3 questions that are all 5s. And that has to do with cough, phlegm, and chest tightness, which is oftentimes a really good indicator and there's clinical data that kind of validates this. It's not just us saying this, but those first 3 questions are a great potential screener for, airway clearance issues. So this is someone that maybe could benefit, maybe from HFCWO, or maybe they don't need to go HFCWO right now, but maybe they get on a flutter valve or they need a mucolytic, but they are struggling with some sort of, airway clearance issue if those first 3 scores are high. Similarly, some of the other things around ADLs, around activity and ambulation, that maybe could just be a need for increasing their oxygen flow. Maybe it's also indicating there's an underlying ventilation issue that's developing that we need to look at some sort of ventilatory support. So breaking that CAT out into the individual questions and highlighting that can help the care team drill in a little more quickly. And then, kind of down here at the bottom, you see kind of a decision matrix. And that's really just to help the care team to see, based off the data and off the assessment, the different fields, what are things that are kind of trending towards, the patient having a potential issue around, in this case, ventilation or airway clearance. So again, just to help those folks that, hey, I've got, 2 minutes, in between patients to look at this. So visually, I want to kind of see where the CAT's trending, where specifically on the CAT are they struggling, and hey, if we're thinking it's ventilation or airway clearance, how many kind of positive checks that tend to indicate that do I have, or where do I have areas that maybe have missing data? A lot of times where we might have a red X is, hey, we got a lot of signs and symptoms. They may benefit or be trending towards a need for some sort of ventilatory support, but we as the navigator, we don't know if they've had an ABG, or maybe they can remember, getting stuck with the needle in the wrist, in the past 6 months, but they certainly aren't going to know the numbers, right, most of the time. So, or have they had a recent PFT? So a lot of times maybe we don't have the data, but it's just the objective testing data. But that's just a highlight to the doc. We got a lot of signs and symptoms, and maybe there's something in their medical record at the doc's office or clinic that can validate that from a testing standpoint. Or if there isn't, hey, we've got everything indicating it. Maybe it might be worth bringing the patient in to do a PFT or to order an ABG. So it's really to kind of just help them, guide them through the process of seeing where does this patient seem to be trending. And then kind of the second page is a little more kind of written form. Again, some docs want to see the graphics and want to see kind of the visuals. Others want to kind of see more of a written summary. So that's kind of provided more at the bottom. So more of that clinical summary note. Our navigators do a great job in kind of that conversation with the patient of capturing some of the feedback, real world feedback, and what we call voice of the patient, to pass on to the doc. So some of the things that the navigator will put into that summary, and we'll put it in quotes, we capture it just as the patient says it is. Patient will talk about, I've had a chronic cough for, the past 6 months or more, and it feels like glue. I've got my phlegm, my mucus, I can't bring it up. It just feels stuck in there. We get some pretty, colorful descriptions, but that really help to paint the story in the patient's own words of what's been going on lately. Or, hey, I used to be able to, do my own grocery shopping. Now I can't walk 20 feet in the house without stopping to catch my breath. So, clearly we, probably have an underlying ventilation issue here that could be developing. So give that feedback, to the physician. So that's, and again, you'll see other formats of this. Different folks have different ways of doing this, but this is just kind of one layout as an example. So again, it's really this idea of stratifying the patient, right? We just keep it as simple as possible. Think of a traffic signal, green, yellow, red. Where do these patients, where are they falling currently? The green zone patients, they don't need to be interacted with as regularly. So that's maybe your 90-day patient. Everything seems to be going great, but we want to still have a regular check-in, because again, we know at some point with a certain subset that decline is going to start, and we want to pick it up earlier versus later. The yellow zone patients are those patients that are starting to trend towards the negative, starting to have some increase in symptoms. And, they may be things that are not necessarily revenue generating for the HME, but it's potentially good patient care, if the physician agrees. It's identifying a gap in care. It's not always about necessarily driving immediate revenue on the home care side. So maybe this is a patient that just needs a change to their medication. Maybe they seem to be indicating that they might benefit from going to pulmonary rehab, or maybe they just need to have be retitrated on their oxygen, because maybe they need to have their oxygen increased. So those are things that are not driving revenue to the DME, but it's helping to identify that gap in care, make sure we're providing good support for the patient. And that's where we see sometimes a differentiator is the physician, the clinic starts to realize that, hey, this HME is different. They're helping me manage these patients. They're identifying things earlier versus later, and helping me to really kind of proactively manage these folks. And again, there are going to be those folks that are the red zone, lack of a better word, it's the 5-alarm fires. They got a CAT score of 38, out of 40, severely impacted with their symptoms, all the classic signs and symptoms, someone who's struggling with either airway clearance or underlying ventilation concern, and sometimes both at once. And we want to get that information to the doc as soon as possible. Seems like this patient might be trending towards an exacerbation or a rehospitalization. Maybe it's a matter of seeing if we can get the patient in to see the doc, maybe they're not scheduled to see the doc for 4 months. Well, can we get them in to see them in the next 2 to 3 days instead, and try and prevent, any more further decline. So that's really kind of the goal of the program there. And it's this idea of kind of creating a funnel, and you can kind of look at this funnel 2 different ways. There's a clinical aspect of it, where you're kind of managing, relatively speaking, these lower acuity patients and being able to proactively manage them and intervene before they get too far down the path of decline, and intervene with whatever necessary care is required. Maybe that's advanced therapy. Maybe, again, it's medication changes. But then, again, there's a clinical aspect to that, and there's a financial aspect. There's a business aspect to that, which is, a lot of times in home care, we tend to think in product categories, right? I got my oxygen patients. I've got, maybe if you have a respiratory pharmacy, I got my nebulizer patients. I've got my vent patients I manage. I've got if you do airway clearance, I got my vest patients I manage. But when in reality, we think about COPD particularly, a lot of times it's the same patient. And it's not these separate, discrete silos of products. It's the same patient or patients that over time are moving through, each channel of therapeutic need. So it's this idea of, hey, let's not, oxygen reimbursement being what it is, it's a challenge. But these patients, at least a certain subset over time, are going to turn into your NIV candidates or your best candidates from a clinical standpoint. So if we can kind of keep in touch with them and hopefully proactively manage, we can identify that need sooner. And the other aspect of this is we want this to be a funnel and not a colander or a sieve with a bunch of holes in it. Because I'm sure those of you that work in home care all have experiences where you've had oxygen patients and you find out after they've been on your service for 6 months, a year, 2 years, lo and behold, they just got put on NIV through my biggest competitor 3 months ago because they went in the hospital, and that competitor happened to do a luncheon 2 days before, or the doc ordered with my competitor out of the clinic because they were in there, a week earlier talking about the things they do around NIV. So it's the idea of not wanting to leak your patient out, and now they're in a higher margin therapy, but they're on service with another company for that. But they're still your oxygen patient. That's the good news. But the NIV's through somebody else. So we want to kind of prevent that as well. So give you some, real world results here. I know we just got a few minutes. We want to leave time for questions. So here's some feedback. So this is what we call a program summary. This is pulled out of a program called Tableau. So we use, that's not anything proprietary to us. Tableau is essentially a data visualization tool. So it helps to take your your big population data and helps to present it in various charts and graphs. It may be a little hard to see from the back. But essentially over 2+ years, about 2.5 years now, we've been doing this oxygen-specific program. We've had over 38,000 patients in the program, a little over 38,500 to be exact. The average, length of service that a patient stays in the program is just a little over 16 months. So these are patients that this is not a transition of care where they're just on for 30 days post-hospitalization and then they're discharged. This is a program, ideally, when it's done correctly, this is long-term management, clinical management of your oxygen patient base. So the average length of service is a little over 16 months for these patients. And what we can see here, this is looking specifically at hospitalizations. Sorry, forgot I got some data here. It'd be easier to read. So what we've seen is that 16-month average length of service. Over that 38,000 plus patient population, we've been able to identify a little over 3,800, so just roughly 10% of those that have a clinical need for some form of advanced therapy. And again, in our world, advanced therapy is NIV, ventilatory support, but specifically NIV or airway clearance, and typically by that we mean HFCWO. So about 10% of those patients over that time period. And what we've seen for HMEs that have used the program is we've seen in general, not every HME that uses this program also does HFCWO therapy, But for those that do, we've seen over a 25% increase in their HFCWO business and about a 20 to 30% increase in their NIV business as a result of using the program. And again, proactively managing, interacting with these patients, and then really working with the care teams to ensure that they're aware of what's going on in the home with the patient in a timely manner. But maybe even more importantly than that is, what we've seen from an overall readmission reduction, and that's kind of shown here on the green side. So if you kind of look at the red column is looking at hospitalization rates prior to being enrolled in the program. The middle column is looking at hospitalization rates on the patients since they were enrolled in the program and actively being managed, and then obviously the difference here. So, essentially, if you round it up, a 70% overall reduction in hospital admission rates or readmission rates on these patients. And if you kind of do the math on that, this kind of shows the total down here. Out of about 2,600 plus admissions, about 600 was reduced to 622, so about almost 2,000, a little under 2,000 hospital admissions that have been avoided. And if you kind of just assign a general dollar amount to the average cost of a hospitalization for a COPD, and this is a low-end conservative number of $7,500, which is very conservative, you're looking at a minimum of about a $15 million savings to the overall healthcare system, just from a savings standpoint. And so what's really cool about a program like Tableau, and again, that's not anything that's proprietary to us, but being able to visualize this population data, when we work with our HME customers, while I'm showing you data across our whole program and all the providers that are using it, as a specific HME that has patients enrolled, their team, whether that's sales, marketing, someone on even the contracting side, can run this data for a specific payer, can run it for a specific doc or a specific health system or ACO. So you can go into the case management team at the large hospital that you're trying to get more of their business out of and say, hey, you realize over the past 12 months, we've taken care of 300 of your oxygen patients. We've put them in this clinical management program, and look at the overall readmission reduction we've been able to drive in that oxygen patient base, and then roughly what that would equate to dollars. We've saved you, just to say $1.5 million in excessive admission costs, and you didn't even realize it. It was just by you giving me these 300 patients. What if you gave me all your oxygen patients or all your chronic respiratory patients? So that ability to start taking real, provable data back to the referral, we think is really cool and really key to being able to drive, better partnerships over time. So real quick, I know I might be, pushing up here on time, but, let's just talk high level, next couple slides. What's some of the responses? So, with every kind of new program, there's successes and there's challenges. So where have we seen success? So where we've seen success is in those HMEs where they take the time to really detail their referral source about the program in advance of bringing in the notes, right? So that ability to go out there with, some sort of brochure that kind of, we can provide that, but, information about what you're going to be doing as far as clinically interacting with these patients and giving them a sample of what the report's going to look like, so that the physician, the mid-levels, the MAs, anyone in that care team that is a decision maker has a good understanding of what this program is, and the fact that they're going to start receiving some sort of semi-regular progress note on these patients. And sometimes it's going to indicate there's some real severe things going on. Also where we've seen HMEs that have good relationship with the referral sources, being able to talk to the doc about, hey, what, kind of, again, we've got the mild, the moderate, and the severe patient. Who are the ones you really want to see the notes on? Given your limited time, time in between patients, the need to review a bunch of charts, sign a bunch of paperwork, what are the notes that's for you important to see? And sometimes it's not always the red zone. We would maybe think 5-alarm fire, but that's not always the case. Sometimes it's, especially if it's a more of a proactive type doc or clinic situation. Hey, I want to see that patient that, if I can intervene and just do a medication change or get them enrolled in pulmonary rehab, and before that trajectory, in their care starts to drop, right, or their progression. So, really working out what's important to the referral, and then, the rep or whoever making sure to bring that information in when they have it. And then we've gotten feedback from physicians, and where we've really gotten feedback from is mid-levels, the nurse practitioners and the PAs, where they really start to see the note once they kind of get used to it. They see it as actually a time saver for them. And we've actually had a couple different docs kind of tell a very, very similar analogy, just slight differences. But essentially, hey, I see my typical patient, COPD patient, 1.4 times a year, or maybe, once every 8 months they're in here. So I haven't seen them for 8 months. I've got maybe 12 minutes with them in the exam room based off my schedule for the day. And I've got to, walk in that exam room, and I've got to spend the first, 6 to 8 minutes of my 12 minutes just kind of asking general questions to figure out why they're in here, what the general concern is, and where do I really need to start drilling in, and pay attention. Whereas if I have a note like this, that is kind of giving me general, kind of 360 information about the patient in the home, it provides me some insight that now when I walk in that room with my 12 minutes, I more or less immediately know where I need to start with my questioning. It saves me 6 minutes of playing detective initially, allows me to drill in right away on some of these kind of key points. So that's where we've had really good response. Where have we seen challenges in programs like this? Depending on the HME, their relationship with the referral, the clinic, we even talked, I think Gene was talking about that, especially with COVID, that access to the physician and the decision makers in the care team, past couple of years has been really tough, right? So getting that face time sometimes to be able to even kind of detail what you're trying to do for their patients can sometimes be difficult depending on the situation. Where we've also had it, and that's why we think it's important to explain the program on the front end, is this is a comprehensive care program. This is a program to help identify gaps in care, not to just get people put on a vent. Because like I said, a lot of these notes aren't going to lead to that. It's going to be a medication change, pulmonary rehab, retitrate on the oxygen. But you will have some docs, I know this might be a shock to some of you who've done home care for a while, but there are, nobody in this room, of course, but I mean, there may be other instances of home cares that have done data mining exercises on patients, right? Have you kind of heard that term? And it can leave a bad taste in the mouth of the doc where they just feel like the DME's fishing for an order and trying to add extra equipment to the patient. So we want to avoid, any confusion around that. And then the other thing I like to say, I don't think there's any payer reps in here. At the end of the day, we don't run or control Humana or United. So qualification guidelines for this equipment is still what it is. So you still have to jump through the hoops of getting them qualified, and with some of the payers these days going through the denial process. What we're trying to do is identify the clinical need and see if there's any supporting documentation, testing-wise, that can support that as well. So kind of real quickly here, data patterns. So diving into data, how can this help us? So here's kind of an example. This is looking at respiratory infections and this idea of uncovering hidden relationships. So this is looking at patients that have reported respiratory infections over the past 12 months. The dark red is 2 or more infections. The orange is 1. So what we got is almost 800 patients here, right? That's a big number to kind of manage, right? So how can we drill in? Okay, so we've got about 99 of that 700 plus that have said they've had 2 or more respiratory infections in the past year. So let's drill into those patients. So you can kind of click on that red part of the circle, and you can say, okay, that's 13% of these patients that are reporting 2 or more infections. I want to look at those patients, and out of those patients that had multiple infections in the past year, how many also have a high CAT score on those first 3 questions of the CAT assessment that tie into a lot of times an airway clearance need. So you can kind of then overlay those 2 pieces of data, and then what you're able to see out of that is out of that initial group of 99, that had multiple infections, there's about a third of them, 32, that also are scoring high on those first 3 questions of CAT. So now that big number of 800 starts to become more manageable and more kind of relevant to the therapist or the care team. And then I can then, by drilling into that, I can get a list of real-world patients here. And I know for you guys it'd be hard to see these white lettering here. But here's a patient here that's reported 6 respiratory infections in the past year, 6. And they score a 5 across the board in those first 3 questions of CAT. This is probably someone I need to have some sort of real interaction with, some sort of follow-up. Maybe that's an RT going to home and doing a deeper dive live assessment to verify some of the virtual data points that have come up. But you can kind of get your list here out of those 33. Who are the folks that are really severe that could benefit? All right, last slide, I promise. So some of that data, what's some of the future we can look at? So you heard talk today about AI, machine learning. How can we continue to, now that we're collecting a lot of this data in the home, whereas before we weren't always able to, how can that help us? We personally are doing some work with Carnegie Mellon, which is world renowned for their machine learning division, Carnegie Mellon University. And we've started to uncover some really interesting things in the data set. Still need to be proved out, but this is just kind of, interesting things around the future. So, the data that we're looking at, over 130,000 patients total, millions of assessments, millions of individual data points, seems to indicate that, if you've got a patient that has a CAT increase of 2, plus the fact that they do not have maintenance medication in the home, has about an 80% correlation to a hospitalization or a future, pending hospitalization. Now, again, that data's got to be shored up. We got to kind of tease that data out a little more, but it's really interesting. Or there's, again, looking at cross-sectional data points, symptoms of daytime hypercapnia, morning headaches, confusion and brain fog, things like that. Plus an answer of, I'm feeling worse than the last time that I spoke to you. Those 2 things coupled together have seemed to show, at least in the data set we've reviewed, about an 88% correlation to having a patient who's got actually a positive diagnosis for respiratory failure. So again, we've got to kind of crunch that data a little more. This hasn't been published or anything yet, but it's really encouraging about what we can get to in the future when we have the data, and now that we have AI, machine learning, to help uncover some of this. Again, what we're doing, that's our program. There's other companies that have their own. There's even HMEs that do their own version of telerespiratory. So the trick is really, there's companies you can outsource these types of things to. There's other HMEs that actually kind of build it themselves in-house. It's really this, decision that each HME has to kind of decide what's best for them. There's not necessarily a wrong or right answer when it comes to that. So there's definitely options out there. So, all right, I think that was 2 minutes to spare, if that. 10 minutes over. Whoops, sorry guys. All right, well, it was the shot clock there. It was confusing
I asked him
me.
if we could shock you, and he said no, because you were his boss. No?
Gotcha. That is true. So, yeah.
So thank you. That was very great data. And so you guys are excused. We have a break.